Hello everyone, welcome to watch CGTN's live stream. I am Yi. Today we are going to continue our special program COVID-19 Frontline in the city of Wuhan, where the coronavirus outbreak began in China. In the program, we invite Chinese frontline doctors to join us, share their first-hand experiences of treating COVID-19 patients with their global peers, in the hope of providing more information for those who are fighting against the pandemic. Today, we are glad to join by two Chinese doctors. They are from Tongji Hospital, affiliated to Tongji Medical College at Huazhong University of Science and Technology, which is one of the best hospitals in China. Both of them have been on the front line of Wuhan's battle against the coronavirus since the very beginning. Thanks for joining us, doctors. Dr. Zheng Hua from the Department of Anesthesiology, and also Dr. Yang Jixin from the Department of Pediatric Surgery. They are going to join a webinar on COVID-19 with their Canadian counterparts from London Health Science Centre in Ontario. Dr. Zheng, could you briefly introduce to our audiences what is the main topic of today's webinar?
Today's webinar is about perioperative management of pediatric patients with COVID-19. We will share our experience with patients with COVID-19.
Thank you so much. For our viewers, we will live broadcast today's webinar between Chinese doctors and Canadian doctors on our app and also our Facebook, Twitter, YouTube, and Sina Weibo channels. If you have any questions for our doctors, please leave them in the comment section of these channels, or you can use the hashtag #MyOpinionOnCovid-19 to share your views. CGTN will take your questions to the professionals later in the live stream. So now I will give the floor to the doctors.
Hello.
Hello.
Hi. Hi, Mohammed.
Yeah, Mohammed is here as well.
Yeah, it's good. So, yeah, you can start your questions.
Hello, guys. Good morning to Wuhan and Dr. Zheng and Dr. Yang.
Hi.
Hi.
Morning.
And we have Mohammed online as well. How did you anticipate the scale of the problem at the beginning of the crisis?
At the beginning of this crisis, I mean, at the end of January, we have, since the outbreak of COVID-19, we have set up a protocol, including how we deal with the patients, the suspected or confirmed patients, and what kind of personal protective equipment should we wear to protect the patients and ourselves, something like that. And we adjust the protocol timely according to the evidence, which we got from this lower coronavirus.
Yeah, so in addition, in the early February, experts from over 20 centers of pediatric surgery have made the consensus about how to deal with the cases with COVID-19, in children. In early February, at the very beginning of the pandemic, so we are very this is very important for directing our work.
Mm. And what are the things that actually your department prepared for this crisis? What are the steps they took?
Yeah, in the department of anesthesiologists, we have two branches of our hospital, which is designated to patients with COVID-19. Since the outbreak of COVID-19, we set up two intubating teams. Yeah, I mean, these two teams is especially for intubation in patients with COVID-19. We have performed over 200 intubation in patients with COVID-19.
With regards to intubation team, how did they operate? And what are the team members comprises of?
The intubation team, including attending physician and resident during each shift, and they will have 24-hour shifts every 3 days. So when perform intubation in patients with COVID-19, there will be attending physician and a resident. Normally, the attending physician will perform the intubation. I mean, we suggest the intubation should be performed by experienced physician, and the resident can be assistant.
And they were given a special place to stay?
You mean for doctors or for patients? You mean
The
for
intubation, where did they stay in the hospital?
normally we perform the intubation in the isolation ward.
Yeah, we have three.
How many wards did you actually create?
We have three zones and 2 channels. The 3 zones are isolated. It's including the clean zone, the semi-contaminated zone, and the contaminated zone. So the incubation should be strictly performed in the contaminated zone. And all the physicians will take a rest in clean zone.
Mm. So what type of PPE, protection equipment did you use?
Yeah, I will show you some pictures about what we use when we perform the intubation. Can you see this picture?
Yes?
Yes, this is level 3 personal protective equipment. When we contact with patients with suspected or confirmed COVID-19 patients, we use this PPE. This PPE including the protective gown, N95 mask, goggles, face shield, 2 layers of gloves, foot covers. And if we perform intubation, yeah, we will extra well head cover like this.
If you need to do the operation, you know, if you need to do the operation, we should use the antibacterial reagent to scrap on your hands and arms instead of washing your hands in this way, and we put on the surgical gown directly, and we put additional gloves addition to this picture.
Did you have to use the PAPR, PAPR?
BiPAP. 用 BiPAP.
You mean use a head cover with positive pressure ventilation?
Yes.
Then sometimes we use that, but normally we use this. This is enough.
And with this, how effective was your protection?
Since the outbreak of COVID-19 in Wuhan, over 30,000 healthcare workers from other cities came to Wuhan, help us to fighting coronavirus. So far, there's none is infected. So in my opinion, if we strict follow the self-protection protocol, being affected can be avoided.
How many of the healthcare workers got infected with COVID by looking after the patients?
In our department, there is 2 or 3 anesthesiologists or affected, because at the beginning of the outbreak, we have no idea to whether to wear PPE or not, especially for patients without clinical magnifications. I mean, they have fevers probably just after operation. So for this kind of patients, our colleagues did not wear PPE, but based on the epidemiological data, the incubation period of COVID-19 patients ranges from 1 to 14 days. So it's recommended when you perform anesthesia or intubation in those in patients without clinic magnifications, the standard protection should be conducted.
So did you so in that case that did you treat all the patients as COVID positive?
Now for all of the patients, before the patients entering the operating room, a triage should be performed by anesthesiologist, including reviewing the medical history, reviewing the CT scans, especially to measure the body temperature. If the patient is suspected or confirmed, the patient will be placed in the isolation area and transferred to the operating room dedicated to patients with COVID-19. If the patient is ruled out as suspected or confirmed patients, we still use the standard protection protocol.
So the patients who were ruled out with the in terms of microbiology, what kind of protection did you use?
Level 2. We use level 2 protection for those patients.
So you used level 2.
Yeah, without the mask.
Mohammed, do you want to ask any questions?
Sure. When you were putting a COVID patient to sleep for intubation, what sort of induction medications would you use?
For the patients with COVID-19, we will perform induction. If there is no difficulty, it's normal airway, sequence induction will be performed. Normally, we will use a small dose of propofol, about 1 to 1.5 milligram per kilogram propofol for patients with stable hemodynamics. For patients with unstable hemodynamics, we will use intermediate, about 1.2 to 1.3 milligram per kilogram. For muscle relaxation must be sufficient. We normally use rocuronium, 1 milligram per kilogram after the patient's loss of consciousness.
Did you find that anyone became very hemodynamically unstable after induction?
Yeah, for critical care patients, the intubation should be finished within 13 seconds, I think. Otherwise, the hemodynamic will be unstable.
When you were looking after these patients, did you need another physician there too to manage the hemodynamics?
As I have mentioned, normally the intubation team, including an attending physician and a resident, the attending physician perform the intubation, and the resident will give the medication and watch the hemodynamic parameter.
Yeah, we're discussing whether we should have 1 or 2 physicians there. We do have a group that feels we should minimize the number of people near the patient during intubation, so only 1 physician.
Mm-hmm.
But the issue of hemodynamic instability has come up, and some people feel it's not a safe thing to do to have just 1 person there managing the airway and the hemodynamics.
Yes, I see. Yeah, if there is limited healthcare workers, I suggest when the anesthesiologist perform intubation, the physician in the ward, I mean, for example, the critical care physician can help the anesthesiologist.
During the crisis, how much information did you have about the prevalence of COVID as the crisis evolved?
At the very,
So,
at the
what
very,
proportion of people that were coming to your hospital or your staff had COVID? Were you doing a lot of testing, or did you presume everybody had COVID if they were coming to your hospital?
so at the very beginning of this, the signs of pandemic in China, we can receive the information updated every day through our apps, and people can see how many people were infected, and how many were being treated, and how many has covered, and how many dies. So all this data are clear, and according to our observation, the patients they can read the information very clearly every day. So do us.
What about your staff? Did you do random testing of your staff to see what the actual prevalence was, or did you base it on symptoms?
We after self-quarantine for over 14 days, we will take the tests, including the nucleic acid test, the CT scanning, and the IgG, IgM testing before we go back to the ward.
I think their connection must be poor.
You hear me? Hello?
Hello, we lost you there.
Yeah, can you hear me?
The picture is still, but we can hear your voice.
Can you hear me now?
Yeah. I
Okay.
can hear you.
Yeah.
Have you heard my answer?
We can hear you, but your video is not coming through.
Yeah, yours too.
Can you hear us?
Yeah, we can hear
We
you.
can hear, but your pictures are still. Yeah.
Maybe you can use the audio to contact with each other.
Yeah, the audience ask us to keep talking. Yeah. Hello?
Okay.
Yeah, if you can hear us, yeah, we can keep talking. Never mind.
Well, reading about Italy and now the United States, they seem to have a high proportion of healthcare workers that are getting infected with COVID. So I think you've done a remarkable job. If only 2 or 3 of your colleagues out of a department of 150 got COVID.
Yeah, I think as I have mentioned, it's very important to wear the PPE when you treat the patients without clinical magnifications. Yeah.
So
The video and sound are cutting out again.
hello? You hear us? Hello? You hear our voice?
Hello, Mohammed, can you hear us?
Can you hear us?
Raju, can you hear us?
For the
Did
viewers,
you have more
just
questions, Roy?
I have a few more questions. Let's see if they can come back.
Yeah, you
Yeah.
hear us? Can you hear us?
I can hear you. I can't. I think the video is not going. Yeah.
Yeah.
Yeah, but if you can hear us, you can keep asking questions.
Yes.
Yeah. So how did you transfer patients within the hospital in a COVID positive patients?
For pediatric patients,
Well,
yeah.
And I have any patients, including pediatrics, including adults.
Yeah, okay. So for patients, we get their mask on, and they only go through the patient's channel. As I mentioned just now, we have three zones and 2 channels. The two channels are the patient channel and the medical staff channel. They are separated, and they will never get crossed. So that is the route we use for transferring these patients. And for neonates, because they cannot put on the mask, they are too small. And the incubator is very important during the transportation. So we use the incubator, the transport incubator, to transport our neonatal patients. They don't put on masks, but the incubator should be thoroughly sterilized after transportation.
Yeah, for patients after surgery, if we want to transfer the patients from OR to ward, if the patient is stable, the extubation can be performed in OR. After that, the patients can transfer to a isolated ward or ward with negative pressure system. During the transfer, the nurse and anesthesiologist need to wear the proper personal protective equipment. And the patients should be covered with a disposable surgical sheet. And as Dr. Yang has mentioned, the patients should wear surgical mask or N95 mask during transfer. If the patient is intubated, not extubation in OR, the patients, we can use a single-use elbow bag during the transfer.
Tell me about your incubation equipment or airway equipment. What are the things you had?
For intubation in patients with COVID-19, normally the video laryngoscope or fibroscope will be used in our hospital because this can significantly increase the distance between the airway of patients and the airway of the anesthesiologist who perform the intubation. If the difficult airway is anticipated, a weak or a fibroblastic or video laryngoscope is recommended. In addition, a kit of cricothyroidotomy or tracheotomy should be prepared.
What are the problems you faced when you were actually putting a patient off to sleep with a COVID positive?
For this kind of patients, I think the pre-oxygenation is difficult. When you use the high flow oxygen during mask pre-oxygenations, it will increase the risk to protect aerosol or droplets. So for the patients with COVID-19, if the invasive method of ventilation is used, for example, the bypass ventilator is used, we will continue use the bypass ventilator to perform pre-oxygenation. Otherwise, we can use the mask. But during the pre-oxygenations, 2 layers of white gauze can be used to cover the mouth and nose of the patients to avoid viral aerosol production.
That's a good point.
Hmm.
This is while the patient's awake or when the patient's asleep?
After patient sleep, but be careful not to abstract the LV of patients when you use 2 layers of white gauze.
Anything else you've found difficult
Uh,
apart from pre-oxygenation?
Normally, the pre-oxygenation can be performed by experienced anesthesiologists alone, but for patients with high BMI or that kind of patients, the attending physician need to be assisted by others, by residents. So we put 2 physicians in an intubation team.
Mm. This intubation team, did they work in the intensive care as well?
Yes.
And also attended the code?
Yeah, they are 24 hours standby.
Okay. So they intubated the patients in the OR as well.
No, this intubation team is especially for intubation in ward or intensive care unit. For the patients receive intubation in the OR, there is another team. This team is especially for anesthesia, for operation, including intubation in OR.
Mohammed, do you have questions?
No, I don't have any other questions, Raju.
And in this crisis, Hua, how did you keep your department morale high?
Yeah. At the very beginning, we read a lot of messages. We don't know which one is valuable, which one is not that real, and we read it for a long time every day. But several days later, our friends and the dean of our department told us, don't watch that too much news, and at most 20 to 30 minutes, that's okay, and then try to relax yourself, try to read some books, read some updates. You cannot watch all the negative news. So reduce the reading online. So that's very important, I think.
Yeah, I think another important thing is to make sure all of your staff received system training about infection control and self-protection to avoid excessive anxiety about coronavirus. For staff, direct contact with COVID-19 patients, psychological support is necessary.
The hospital-acquired infection control department have given us several trainings at the very beginning of this pandemic. So we are very confident.
Excellent.
Yeah.
One more question, it's more technical, on the technical grounds. Why did you choose negative pressure ORs than positive pressure ORs?
Yeah, because the OR with negative pressure system will reduce the risk to expand the aerosol and droplets from the OR dedicated to patients with COVID-19 to other relative clear OR room.
We have in our center positive pressure room with laminar flow.
Mm-hmm.
What advice will you give?
I think if you perform a surgery in OR with positive pressure system, the positive pressure system should be turned off, and the air condition should also be turned off, because air condition is similar to a positive pressure system.
and this will probably cut down the intertransfection in different ORs.
Okay. Is there any advice you want to give us?
Yeah, as I have mentioned, the PPE, the anesthesiologist is at a high risk to get infected because the intubation, extubation, ventilation, PCR, etc. are all high risk procedures. So it's very important to follow the strict protective protocol for anesthesiologist.
The pediatric surgeon, what kind of children come into the hospital for surgery in this pandemic area, and what are the problems you found with this population?
Well, for in this 2 months, we highly suggested that all patients with the selected, they were anticipated to take the selected operations should be postponed to after the pandemic of this disease. But for the urgent cases, just like the intra-organ hemorrhage and perforation, or a lot of the neonatal cases, we must do the operation right away, and we should put on the level 3 protection for ourselves.
And
I forgot to mention that for some cases they were not that urgent, but you need to do it in a limited period, just like the biliary atresia, the tumor, malignant tumors. If you don't do it in time, it may aggravate the prognosis. So for these cases, we should select a time for them to operate. So that's my suggestion.
how about sedation procedures? For example, children coming in for CT scan or MRI or lumbar puncture. How did you manage those?
For this kind of patients, I mean, the sedation in this kind of patients is performed not so many such kind of patients in since the outbreak of COVID-19, because we suggest would unnecessary come to the hospital if the patients the procedure is not so urgency.
For example, the oncology chemotherapy kids cannot wait until the pandemic. So how did you manage those kids?
Actually, the patients with chemotherapy is begin just since the beginning of last week, I think. Is all of this therapy is cancelled during the last 2 months.
Yeah.
Oh.
Mm-hmm. Because these kind of patients are at a higher risk getting infected and become critically ill patients. So it's difficult. It's difficult to balance the chemotherapy and the risk of getting infected.
Those patients are very special groups. Besides this, patients needs chemotherapy. Those who received organ transplantation also have this similar problem. They are the group of people that we very emphasized.
think, Mohammed, do you have any questions? You have to unmute your mic.
Oh, yes. Do you have much respiratory disease in Wuhan, like from smoking or environmental reasons?
Yeah. I think this reason is difficult to
Evaluate.
yeah, because the most popular risk is get infected by coronavirus, and the patients with smoke history and some other medical history will be not paid too much attention to besides this coronavirus infected.
At very beginning,
We exacerbate the respiratory disease from coronavirus. That's why I was asking.
Mm-hmm.
Yeah, that's all I have.
Thank you, guys.
Thank you.
Thank you.
Thank you, and I hope all of you guys stay safe and healthy.
Stay strong. Yeah.
Thank you. Thank you for your
Thank you, Dr. Yang.
Thank you.
Yeah. Bye.
Bye-bye.
Bye. Thank you, CCTV, CCTN.
Thank you so much for joining us, doctors from China and Canada.
Thank you.
Thank you. Bye for now. So now it's my turn. We have collected some questions from our viewers online. I will read their questions. Well, the first question from Facebook. Could you introduce to our audiences the death rates in China of COVID-19 or the death rates in your hospital?
Death rates in our hospital so far, I think, is 3 point or about 3 point.
The treatment is not over yet. So before that, we don't have a definite data. That's the first one. The second one is in Tongji Hospital, all we have is very severe cases. So the death rate is does not represent the common death rate.
So the death rate will be higher than the average death rate in China, in the whole country.
Yes.
Yeah.
And we have another question that a lot of cases in China have already recovered. People are wondering, will they be reinfected
You mean the
after they recovered?
Yeah, you mean the symptomatic patients?
Yes.
Yeah, the patients without clinical manifestations. For this kind of patients, normally they will tested and confirmed with the PCR test, and it's not clear whether this kind of patients is had at high risk of infecting others. So we suggest if the patients with positive PCR test result, the patients should be isolated, and in dedicated hospital.
The reinfection rate, there is no official data yet, but for from the news, we may see some isolated cases, but that probably does not represent for a very common cases.
Okay. And another question, how dangerous are the asymptomatic cases? How do people know that they are one of the asymptomatic case?
If you have contact with the patients, with suspected or confirmed patients, we suggest to, at first, to measure your body temperature every day, and to, if necessary, to go to the dedicated designated hospital to get a PCR test to figure out whether you are asymptomatic patients or not.
Okay, thank you. And also, we can see that a lot of people in other countries, they don't wear a mask in the public. They only keep social distancing. What protection should they need to know when they are going out shopping? Will they be safe not wearing a mask?
I think this difference is normally because of the cultural difference between different countries. So according to experience in China, the early identification, isolation is the most effective way to prevent the expansion of coronavirus. So we suggest the people from other countries also wear masks, even go shopping or in some situation.
This is the safest way
Yeah.
to protect
Yes.
themselves. And also, how do we distinguish the mild, severe, or critically ill symptoms? Because in other countries, some mild cases, they are recommended to stay at home, to self-quarantine. So how do they know they are developing to the severe cases? What should they know?
The people with all of the with the coronavirus can affect the people in different ages group, but people with medical history, especially the elderly, are at a higher risk of become the critically ill patients. So if your symptom, normally the fever get worse after you take medicine or isolation at home for several days, 3 days or 6 days, even the symptom even get worse, and it's suggested to present at the emergency department or some department in the hospital.
The dyspnea is a very important sign for the moderate or the severe cases, right? If a person cannot respire very freely, if you cannot hold your breath for over 10 seconds, that means this may be begin to become severe. Yeah, so
That's when they
a
are going to see the doctor in the hospital.
dyspnea. Yeah.
Okay. Thank you so much for your insights. Thanks again for joining us. For our viewers, CGTN will provide more episodes of the special program COVID-19 Frontline in the coming days. Thanks for watching. See you next time.
Bye-bye.